So, meibomian gland function is always associated with slit lamp changes. I guess the question is, if you don't see slit lamp changes in meibomian gland dysfunction, do you still use IPL in dry eye?
I suppose my comment on that is, Rick, is I would always express the glands, because that's the best sign. If you just sort of zoom across the actual lid margin, you could miss some people.
As a diagnosis, you know.
As diagnostically. So yeah, so we'll find now, we might ask them symptoms about their dry eye, but as part of that preoperative process, we will always go along and actually just do a digital expression on the lid margin to see what comes out. And sometimes you'll be quite amazed where their lashes look clean, the lid margins look fine, and you actually press on the gland, and out comes this really turbid oil. So it's not always obvious, you know, that they've got a problem until you actually express the gland. So to me, they're not normal until I can press gently on their eyelid margin and see a lovely clear meibum. That's when I say, yes, you haven't got a problem.
Thank you.
I think our world has changed, because over the last 20 years, I'm seeing more and more of that, where you try to express glands and there's just either nothing is coming out or you get bad stuff coming out. I just don't think we're blinking as much. We're not taking care of ourselves as much. I know in our family, we have Netflix, Amazon Prime, Paramount. I mean, it's just like all day long. And patients are coming in, I ask them what they do, and they're just staring at screens all day long. So what do you do at work? I stare at a screen. And then after you get on the screen, what do you do as a break? I stare at a screen. It's Facebook. All this is just changing the landscape so that more and more patients have meibomian gland.
So you explain, so the lack of lid movement lacks the pumping of meibomian secretion, does it?
Yeah.
Okay.
Yeah, there's one little paper that looked at it. What's fascinating for me is, unless the eyelid's completely touched, there's a little tiny muscle around the head of the gland. It doesn't properly relax. So if you don't get that proper lid-on-lid interaction, you don't get the secretion of the meibum, which is often why the inferior glands often fare worse.
We know rubbing eyes causes keratoconus, maybe the only cause of it. But it might be good for meibomian glands, is it?
No, I think you have to. So in Japan, they're making their workers take a 5-minute break where they actually close their eyes, they cover to block out light, and they actually think, the Japanese way, think of a rock garden or a stream or something like that. So I don't do that, but what I tell patients is take a 2-minute break. The other thing that I do, and this is an old yoga trick, just rub right here for 30 or 40 seconds. It gives a little bit of warmth, and then take the break and then put that over their eyes. And it's amazing how many patients say just doing that every hour has helped. No pressure, no pressure. It's just right there. It's like it's a homemade, it's like your own body warm compress, but it actually makes you take a second to stop and keep those eyes closed, and then afterwards you're doing a little bit of blinking as well.
Sure. I called you an iconoclast before because you took away every dry eye treatment that most practitioners use as eye drops, massage, and lid hygiene. You said these were you joking, or is it a relative truth, or you're trying to get our attention?
Well, think about this. So 2 things were mentioned, one by each speaker, that, sometimes I hear them now and it's like chalk, nails on a chalkboard. So Systane 8 times. So Systane as a drop was never made to be used 8 times a day, 12 times a day, 14 times a day. It doesn't have BAK, but it has boric acid. A lot of our drops have boric acid that we're using post-surgery, but they're only using it 1 or 2 times a day. Boric acid is the same thing that's used in roach killer. So just think about that. So you're putting boric acid, so everybody worries about BAK, but there's studies out of University of San Francisco School of Optometry showing boric acid breaks down the epithelium. So when patients come in and say, yeah, I've been using Systane for the last 3 years, 12 times a day, and you look at their cornea, you look at lissamine, that's what I was saying before, lissamine green, they have conjunctivasis, their lissamine green staining all over their conjunctiva, their cornea looks ratty, And this is because some of the things that they're doing that they think are helping them are hurting them. Then before, tea tree oil was mentioned. So there's a study showing that tea tree oil is cytotoxic to the meibomian gland cells. So all this time that we were going, hey, let's do some tea tree oil for Demodex, which I've never seen works very well, is cytotoxic to the meibomian glands. So some of the things that we're prescribing are actually, you can put under medicamentosa that's actually making the problem worse.
Okay.
Well, I suppose, to put it in context though, as Lena would agree too, there's such a diversity of dry eye. So for some patients, initially, an eye drop is an absolutely, an initial go-to. I think, for both of us too, we see the pointy end where they've had dry eye and they've used eye drops for the first 5 years, and they sort of got worse, and they started using some hot compresses for another 3 or 4 years, and they find it up at us, at their wits' end. So I think, from what we're discussing today, we come here with you guys, you're here on a Sunday. I'm hoping you've sort of got to the point where you've exhausted eye drops, which just manage your symptoms, and you've exhausted other treatments. And what I want to share to you, is there is this way to get to that root cause of the problem. But I find, like in my practice, really the same. And I've got like the whole airline philosophy of like bronze, silver, and gold. Right? And gold treatment is my IPL, which gets to the root cause and seeks the problem. But not everyone wants to fly gold or can't afford to fly gold. So you need to be aware of the other treatments. But the key is to know what makes a difference and what doesn't make a difference. So, it's holistic. Dry eye management is holistic. And, IPL is absolutely the top shelf. But you will find in any given practice, you need a range of ideas to help people. And often they need time to think about it. And they might leave with their eye lubricants 4 times a day and a brochure on IPL. And then a year later they come in going, those drops, after you use them 6 times a day or they've stopped working. And that's when you talk about IPL. And we call it the shoulder pat in cataract surgery. They'll come in with cataracts, but you can tell they're not quite sure. We go, you've got cataracts, but they're only mild, see you in 6 months. They're ready to be done that day, but psychologically they're not ready to have their cataracts treated. And so dry eye is the same. Often the idea of going straight out of the gate to IPL may not always be the way you go. But it's all in context.
And especially if we can go looking for inflammation for these patients as well. So if we can find there's no signs of inflammation there, and patients are pretty happy with mild symptoms, they're happy to use drops, great. But if we can try and catch inflammation early on and treat it, that's going to really help them long term.
I wonder if the audience might like to ask some questions. This is a fantastic opportunity to find stuff out. I mean, you can sit and watch us talk amongst ourselves all day if you want, but it's just not as interesting as answering your own questions. If you'd like, you've got a microphone, please.
I have a microphone. I actually have a lot of questions, but...
Ask them all.
So with gland expression, there are some patients that just never secrete. In that case, it's hard to quantify kind of how the treatment's going. Some of them are glaucoma patients who are using prostaglandin analogues. I think that contributes to the inflammation. What do you do in that case when the patient says to you, are you getting the butter or are you getting the toothpaste, and you're getting nothing?
So early on, I had this woman from Wisconsin. So she was traveling with her husband 10 hours, and I was doing IPL after IPL after IPL, just like that. So terrible meibomian gland dysfunction. Nothing was coming out, and this was early days. So this wasn't now with Optolite and what I know now. And it was getting to like 7, 8, 9, 10 in a row, and I was like, I'm still not getting anything out of these glands. And she goes, but I feel better. And I don't know why she was saying she felt better. I want to keep getting treatments. So we had a breakthrough around 16 treatments where actually I was starting to get stuff out. And now she's stable and she comes every 3 months for maintenance treatment. So there's something to photobiomodulation, and there's something with cells that take much longer for the mitochondria to be stimulated and go. And that's why I was saying earlier, younger patients respond a lot better. They have young cells that get energized pretty quickly. Now knowing what I know with her, I would have done more. I would have done astragalus, I would have done NAD, I would have done B12 injections. I would have done things to supplement what I was doing with IPL. So I don't have 16 treatments in a row anymore because I'm doing stuff that with diet, and, supplements, and other things to stimulate those cells to work better.
Dr. Torres, can I ask you, have you started a conversation about diet for patients?
It's the first, I block out a lot of time for that first time that the patient comes in, because I know I'm going to have a long discussion with them into treatments and going back to what you were saying, the pat on the back. So it's a long discussion so that they can feel comfortable with what we're going to do. But I immediately get into diet, and they appreciate it. They go, my general doctor doesn't even talk to me about diet, and you could be the first one telling them about some of these things to improve their lifestyle. So I've had patients that not only have improved their meibomian gland dysfunction and dry eye, but they've lost weight, they've improved their lifestyle, they have a better, I'll give you a perfect example. I had a woman, she was suicidal. She told me that going into it. Now she's been my patient for 12 years, so she shows me pictures of, she's married now, 2 kids, and she said, you changed my diet, you changed my outlook on life, you did IPL, I found something that I can cling on to, going, this is something that's helping the root cause, not just helping the symptoms. So, your impact can be immeasurable for your patients because you're dealing with dry eye.
So what is the meibomian diet?
So you want a non-inflammatory diet. So this is going to sound harsh. So no meats, no eggs, no dairy. Those get broken down in the body into arachidonic acid. Arachidonic acid is broken out into prostaglandins, and those are inflammatory. To change your gut bacteria now, I'm telling them you're going to have to go straight onto a 2-month vegan diet. Do the best you can. Before you start introducing other things, you got to do the 2 months. And what you'll find is, if a patient can go on a strict diet, then they don't want to break that diet. So I've had big time, and I'm not saying if you're eating meat and chicken and all that other stuff and you're doing fine, but we now know that there's a genetic component to disease, so that you could have somebody that smokes 3 packs a day for 30 years and never get lung cancer, but you can have somebody that's never smoked and gets lung cancer. And it's that there's the genetic part of our body makeup that somebody that has a systemic inflammatory disease can't handle an inflammatory diet. Somebody that doesn't have a systemic inflammatory disease, they can eat whatever they want and they never have any problems with their meibomian glands in their dry eye. So this is the fine line, but missing out on that opportunity to change their life is an opportunity that you shouldn't miss.
I think on your case too, like for me, I make sure I did meibography as well. Right? And if you see glands on meibography, you just got to keep going. Right? And use it in context too, in terms of how much meibum to see. Like we're sort of discussing expression, like I love expression. But if I've done meibography and they're grade 4 and the gland's only this long, I don't squeeze for 8 hours because the gland's only that long, right? But if I see a meibography, a longer gland, I'll squeeze and I'll squeeze, And so for me, it's often multiple passes, and I make sure that I empty the gland. And you'll often see the meibum will change. It'll start off quite thick, and as you express it down the bottom, it becomes clearer. I'll often document, after IPL1, capped gland followed by thick meibum. And then IPL2 is thick meibum followed by cloudy meibum. IPL3 is cloudy meibum followed by clear meibum. And you'll actually see, as you express the gland, as you were alluding to, the top of the gland, the terminal is often like the poorest quality meibum. And I always make sure I completely empty the glands from an IPL treatment to give that gland a chance to start to regenerate new meibum. And you'll find it will change. And I actually document not just the single expression point, but how does that expression change throughout the process? And you will see it will vary across your IPL course.
And there's a reason for what you just said. So this goes back to the toothpaste example that I give you. Go home, take toothpaste, squeeze a little bit out, take the cap off and leave it there. Come back to it the next day. What will you see? You'll see that toothpaste with air will harden, it'll get thick, and then you try to squeeze the tube and nothing will come out. That's the same thing that's going on here. That's why you have those caps of toothpaste that are blocking any kind of secretion coming out.
Have another question from the audience? Yeah, good. Thank you. Please.
Um, talking about supplements, you mentioned B12 IV. Is there
Injection, yeah.
injection? Is there a reason you didn't go sublingual
You do
spray?
sublingual too.
Because that seems to lift it in the bloods, so that's okay. What would you recommend as a schedule for NAD and B12? How long? How often?
So the ones I'm recommending now are an omega-3 unless they have some like they're vegan and they don't want to take an omega-3. Then B12, NAD, astragalus. I actually put them on macular vitamins as well for the lutein and zeaxanthin. When COVID hit, I put people on zinc and vitamin D, and it has some elderberry, and then vitamin C. And these are the same things that I take on a daily basis, and I have been taking for several years.
So as in forever?
Yes.
Gotcha.
These are forever behavioral modifications and dietary modifications. And if you look, in all these things that I do, I've actually tried them myself, but there's so much science supporting them that nobody can argue against it.
There's a fabulous book by an Australian who works at Harvard, David A. Sinclair, popular. And I've gone on an NAD. I mean, this whole book is about extending the life of yeasts and whatever. But the best thing you do to extend your life is to take NAD, in his view. I think.
Yeah.
I do it every day.
Yeah, the science, there's no real people promoting. It's not like the beef industry or the poultry industry or all these other industries. They're really not promoting this stuff, but the science is completely clear and there's no disputing it.
Mm-hmm.
Like for example, there's another thing called sirtuins, and you can look at anti-aging, and chicken is like one of the worst in terms of decreasing sirtuins and decreasing our life. In America, we actually chlorinate our chickens, so we're the only country that chlorinates our chickens. So usually I mention that to my patients, they go, what? I go, yeah. I mean, it's like you're jumping in a pool of chlorine and getting that every day when they tell me, oh, I have a really healthy diet. I said, what are you eating? Oh, I'm chicken and eggs and milk, and but they're farm raised chickens. Well, they still get chlorinated. So really, our diet is killing us, is destroying us. If you watch Forks versus Knives or any of these things. So I wrote a book on optimum health in the pandemic age, and if you look at the blue zones, they're not eating the diet, but and they live longer. As soon as they go to a Western diet, they start dying. These people that usually live till 90, they go to a Western diet and they just. So it's so funny when I go to a dry eye lecture and that's not mentioned. Diet is not mentioned at all, and I go, well, then you're not dealing with dry eye.
Diet and lifestyle.
Grab the mic. Are you recording it? So you get recording it. Take the microphone so you.
If you've told them to go on a vegan diet for 2 months, and with the omega-3, could they still take omega-3 fish oil?
I do. If they have no social, political problem with taking the omega-3.
And then how many milligrams a day do you tell them to take?
They get 1,000 milligrams of its triglyceride-based omega-3 that has enteric coating, so that they don't get. Usually, the number one reason why people will stop omega-3 is upset stomach. So all of these vitamins, I tell them to take with a meal, their heaviest meal of the day, whichever meal that is. But I just think you need 1,000 milligrams of a good omega-3 daily, and that will be enough. It's funny because I have a group of patients, I did this early on, that they were on doxycycline, and I looked at and before I did IPL or anything, I just wanted to see for myself. They were on doxycycline, they'd been on it for at least 3 months, and I was looking at their meibomian glands, and the only thing that I changed was I put them on this enteric-coated 1,000 milligram triglyceride omega-3, and you could see a difference right away in their meibum. So if I had a choice between, I don't use Doxy, it's not even in my vocabulary anymore, but if I had a choice between taking Doxy every day and taking omega-3, I would take an omega-3.
Triglyceride form as well. It's far better absorbed by the body. So there's so many brands of fish oil on the market, unless it says triglyceride form, only 30 or 40% is actually getting absorbed by the body.
So where that comes from is the omega-3 is already in a triglyceride form. When they actually wash it to take away toxicities, they're washing away the triglycerides. So most companies just stop there. This is the cheapest way to do it. Here's your omega-3. It's not absorbed, as he's saying. The companies that are making a triglyceride, they have to put those triglycerides back on the chain and make it like it was before. So that's the whole process with an omega-3. And there's more now than there ever was before. There was only 3 that I would recommend when a patient would come in, but now there's more. I think patients are getting smarter. They're asking what kind of omega-3 they're getting. The supplement market, I don't know about here in Australia, but it's not very well regulated in the United States, so you don't know if you're getting what you think you're getting.
Yeah, they say they're on omega-3. Don't just go omega-3 check. Ask them to bring it in, or a picture of the bottle. Because sometimes you think, oh, that's covered, and they're taking something that's full of, horsehair and God knows what else. So get them to bring it in so you can check what they're actually on, rather than assume they're on omega-3, because it may not be a good product or a good dose.
Please ask your question.
Oh, thank you. Just wanted to know your experience on sort of single or spot treatments for chalazions, and how have you gone about that in practice? So if we were told, we just recently got an IPL machine in our practice, and we're sort of trying to work out our protocol and how we, tell patients about it and how we'd run the protocol with the patients. And we were also told that a single sort of treatment for someone who walks in with a chalazion or a hordeolum will help within 10 minutes, or pretty quickly you'll see a result. Just wanted to know, is that true? Thank you.
So that's where the Optolite comes in. It's perfect for doing a little spot treatment. So you don't want to do a full IPL treatment for that patient to come in. So it's the same protocol. You're going to use the same energy that you would normally use. You'd look at the skin, decide whether they're type 1 versus type 5, type 6. I'm doing darker and darker skin types, and when we do the demonstration, I can show you my protocols to do that. Give them 2 shots of energy to that spot, and I still, usually they're very sensitive. I still try to do some expression, because if you looked at the one picture that I showed, what happens is once they get capped, the normal flow of meibum is up. But once they get a cap, what happens is the normal the flow of meibum goes in reverse and goes down. So what you're trying to do is, you've got that gland opened up a little bit, try to get the reverse going the other way. They're going to be a little sensitive. It's a brand new hordeolum, but you don't need a lot of hard pressure. You just need to decrease the viscosity of the meibum, constant pressure. So not hard pressure, just a little constant pressure, what they can take, and just leave it there for about 30 seconds. Then I hit them with a steroid antibiotic, and usually in about 1 week, it will go away. If it's not, like for example, I had a woman that was ready to go to her wedding. Her wedding was Saturday. She came in with a huge one on Monday. She was falling apart. Oh, I can't believe this. And I was like, well, Photoshop. No. So we hit her twice. So in day 1, and then she came back 3 days later, and we hit her again. Same energy levels.
Dr. Laura Perriman did a little case report she published, I think it was at Arvo, but she had a whole mixture of acute and chronic chalazions, and it goes through just what she found and the energy that she used. And for a lot of hers, it was a single pulse treatment, and they were all viewed at 6 weeks, and most of them were okay. But once again, don't say 20 minutes recovery. I would say it should get better in a week. Just give it a bit of breathing space. But look, absolutely, it's a nice little in between. Like often they come to you, they've been told hot compresses and Chlorsic ointment, rather than go straight to being curetted or injecting some A10. You can do IPL to help them out.
Thank you very much. I'd like to thank the panel very much. It was an excellent session.
Sorry, just one more question here, Dr. Wolf.
Oh.
Sorry, just one more question. Are you now recommending the treatment for both upper and lower lids now for all your patients?
Yes.
And if they have tattooing of the eyebrows and eyeliner, do you warn them that they'll lose some of that pigmentation?
I've never seen a patient lose pigmentation from, and I'll talk about it in another one of the sessions. But actually, I've never seen permanent eyeliner come off with IPL affect anything with IPL. The upper lid is something I've worked on for so long, as I was saying before, and you'll see in the anatomy. The anatomy of the upper lid is very different than the anatomy of the lower lid. The skin is thinner. You've got the orbital rim to contend with. It's small space, nowhere for that energy level to go. So that's why we developed the Optolite pen. So I published a paper in 2017 showing energy levels and using a special pencil tip to treat the upper lid. And now that I've got it down, and I'm taking advantage of the fact that we have the Optolite to do that. So we get upper and lower. I still think that you could get away with just doing lower. Patients will get better. They are getting some energy there, but as I said before, what I found is if you can give direct energy, you will get more photobiomodulation than just getting dispersed energy.
Thanks very much. So it's time for us to go to lunch.
Do you know one more?
I just got
What?
just one last.
She's very excited.
You really want to take it? You want to take it? Okay. Please.
Thank you.
Special request.
Oh, thank you.
See, this is a dry eye conference. See, cataract people would be going for the food. Dry eye, people are like excited. We'll eat later.
So regarding treatments, I know you can do 2 to 4 weeks apart. Do you have a preference, or do you find you have better results doing 4 weeks apart or 2 weeks apart?
The reason why we had to do 4 to 6 weeks apart in the early stuff that I wrote and the videos and all that other stuff is that we didn't have a chiller. So what was happening is we were burning epidermis, and you needed to give time for that epidermis to regenerate. So that's why I would wait at least 4 weeks. Since we have the chiller, we don't have to wait. So I like going 2 weeks and getting it, back to back treatments. I actually find that they respond quicker and faster, which is better for the patient mentally that you're actually doing something. And I'll give you a perfect example. In the old days, when I'd wait 4 to 6 weeks, what was happening is patients they want to be proactive in their disease. So a patient would come back and we'd just be starting in the IPL protocol, and I go, so how are things going? Good, doctor, I just want to tell you, I've seen 4 other doctors since your last IPL treatment, and I got this, 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 and this, which was totally against what I wanted them to do. So I like the 2-week protocol because they feel like they're doing something to make their dry eye better quicker, and it works. And you don't have to worry about epidermis because you're not burning epidermis. See, that was an important question.
Right, it was important. Thank you very much. Okay, so we're running a little late, but we'll take it out at lunchtime. I'll see you back here at 12:45.